TeamHealth's Emerging Infectious Disease Task Force has worked tirelessly since the beginning of the COVID-19 pandemic to provide state-of-the-art guidance to our clinicians and leaders in the field. We recently recorded a webinar providing an overview of the pandemic and the opportunity to learn more about COVID-19 as it presents in various care delivery areas. To synthesize what we've learned about the virus in a concise manner, TeamHealth's clinical service line leadership tracked COVID-19 patients through ambulatory care, emergency medicine, anesthesiology, hospital medicine, and the post-acute care experiences. They also discussed the potential exposure to an obstetrics patient. Please join us as we walk the path of the patient during COVID-19.
I did want to give everyone the ambulatory retail view of what has happened since COVID. So the retail volume trends. Let's take a look. What we describe as the almost V. No doubt everybody knows what this view is. This is the Dow Jones, and taking a look, it took a big dip and almost returned. This is a view from the UCA benchmarking data, which showed trends of volume from this year compared to last year. You don't see everything on the left-hand side, but that was at 100%. But you can see the big dip and the return almost back to normal, about 25% to that. This is actually the ambulatory view. Pretty similar. Decrease in some cases as much as 65 to 70%. We're now back to within 25% of what our volumes were last year. So the almost V. But how do we get patients back? Well, really testing, and marketing. We started antibody testing in mid-May, and that really provided a bounce back to our volumes. Now we're seeing molecular testing become much more popular with people returning back to work. Marketing, very important. Much like you see in Starbucks or other retail settings, people want to know, what are you doing to keep us safe, to let us come back? What you see on the right side is actually taken from one of our websites, one of our facilities, on what we're doing, a little bit about testing and knowing a bit of the basics. We actually became creative. We created safe centers where we had non-respiratory patients come. They're really occupational medicine centers, so really doing different things to bring patients back. What are the hurdles? Well, a lot of these are not new, so take a look at really clinical, providing education, providing guidelines, and this is something that the Emerging Infectious Disease Task Force has really helped. One of the most impactful quotes that one of my providers said was that they were grateful for having this job, but they're also terrified of the job. So really a lot of communication, a lot of information on what COVID is and how to treat it. Also maintaining adequate PPE is something that we, as everybody else, has to deal with. We changed a few of our processes. We kept patients waiting outside, triaging them outdoors and bringing them back right away, or actually keeping them in their car. We also have dedicated rooms, and certain things such as nebulized treatments we are doing less now. Other hurdles that we're seeing is the next wave. What's going to happen with the flu season, with COVID season? Now, in the retail setting, in our urgent cares, we have to make these decisions now about testing, to purchase these tests to get them on time for the fall. Is it just going to be COVID testing? Is there going to be a flu test with it? Most likely. Is there going to be a strep and RSV? So you can see a hurdle is we may be doubling or even more, tripling some of our lab costs that we have to think about right now. The other things are, what's the availability of testing? What's the turnaround time? And who's going to cover this? Will the insurance cover people who are coming in just worried that they may have it? Still some things to figure out. And now looking at the new norm, what do we think the new norm is going to look like? So you recall that the V-shape didn't completely go back to 100%. Again, we're about 25% off. We think that that gap of about 25% could be made up in telemedicine. And this telemedicine is different in that it's a direct-to-consumer telemedicine. We think we need to be more versatile. There may be some primary care opportunities being part of a larger continuum. So these are all certain things that we're anticipating. PPE, as you know, we had questionnaires about for all the FMDs about what do we think it's going to look like. We, at the retail setting, urgent cares, We think PPE is here to stay, that really patients as well as the providers and clinical staff will need to have PPE really at all times. Molecular testing. So we talked about testing, but as we spoke of, some of this testing has a long turnaround time, and it seems like that's growing. Point of care testing, where I can get results back in 15 minutes, we think that's going to be really the differentiator. And who does that apply to? Is it cash pay? Is it employers? Still to be determined. We need to be flexible, and no doubt not only our schedules to be flexible according to volumes, but also the hours of operations. We have a facility in Florida which was seeing about 20 to 30 patients, but now with the spike in cases in Florida, a few weeks ago we were seeing in the 90s and the hundreds. So we can go from feast to famine and vice versa very quickly. This is also new opportunities. There's a lot of centers that may not be operating quite as efficiently as we are, and they may be wounded, so to speak. This may be opportunity for growth. So I do want to present a case presentation that will follow through the course of this patient's illness and locations. So this is Miss Richards, not uncommon, 78-year-old patient who's had some respiratory symptoms for a few days, but at home fell. Granddaughter, who happens to be pregnant, actually brought her into the urgent care centers. So if you take a look at her vitals, this is the classic on the fence. Little tachycardic, maybe a little hypotensive, little tachypnic, low-grade fever, and a pulse ox of 92%. Our review systems is negative, aside from the above. Now in the exam, we see a frail elderly patient, really some rails in her lung exam, as well as some difficulty with movement in the right side of her lower extremity. X-rays done in our facilities do show a right hip fracture. So what to do next? In this case, we will refer this patient up to the emergency room, where we call and speak with Dr. Heather Owen.
And thank you, Dr. Chow, for the transfer. In the few minutes that we have together, I want to share with you some of the most pertinent information regarding the care of COVID patients in the emergency department. An emergency medicine approach to COVID-19 should focus on identifying and isolating patients at risk for infection, completing an appropriate workup, and stabilizing and admitting those that require acute care. Identifying those patients appropriate for discharge is an important aspect of the care we provide as well. Upon arrival to the ED, all of our patients should be masked to protect frontline physicians and staff. The CDC's current guidelines now say that if you're caring for a COVID-19 patient, that you should wear an N95 if one is available. This is consistent with our recent survey, in which 84% of our ED clinicians report routinely wearing N95 masks. The CDC also recommends a surgical mask in areas that have moderate to substantial community transmission, and they recommend eye protection. They have all along for COVID-19, but now they recommend it even for routine care. TeamHealth remains committed to the safety of our frontline clinicians and will continue to monitor for critical PPE needs. Let's pick up where Ms. Richards arrives into the ED. So upon arrival, she's already masked, of course, and identified as a potential COVID patient. She'll be placed in a COVID cohort area. ED should have cohort areas to put these patients that are presenting with respiratory illness and COVID-like symptoms. There's a New England Journal article by Laura Wong and Associates that addresses maximizing our ED operations and caring for our COVID patients while maintaining a safe environment for our non-COVID patients as well. I recommend you review this article. It provides some great insight on the value of appropriately triaging these patients, but it also may be of interest to those of you in low COVID areas, as it provides some practical recommendations to encourage the community to feel safe returning to the ED. So Ms. Richards is placed in the department's COVID pod, which is an airborne plus isolation area. Her emergency physician comes in to evaluate her, of course, in full PPE. She reports very typical symptoms for COVID-19, fever, dry cough, fatigue. Let me take just a minute and share some interesting data, comparing commonly reported symptoms of COVID to influenza. I think this will be very valuable as we enter the fall and we start to see flu outbreaks right alongside COVID. So here on this chart, you can see a comparison. This is kind of a reasonable approach to help you with your history taking. And presence of fever, dry cough, nasal congestion, absence of nasal congestion, runny nose, and chills would be consistent with COVID-like symptoms. And it's also noteworthy, as I'm sure you have all seen, that loss of taste and smell seem to be very specific to COVID. So on exam, Ms. Richards is acutely ill. She's tachycardic, she's tachypnic, she's got increased work of breathing. Her right lower extremity is everted, it's shortened on exam. So per NIH guidelines, the laboratory testing that she'll receive should include a CBC with differential, a metabolic profile, including liver and renal function tests, measurements of inflammatory markers such as C-reactive protein, D-dimer, and ferritin have prognostic value and therefore are frequently added. She'll, of course, receive a chest X-ray, an EKG, and a COVID test. Some of the pertinent clinical information regarding the stabilization of our COVID patients, such as early treatment, recommendations, and airway will be covered in the hospital medicine and the critical care aspect, the anesthesiology portions of the call today. So Ms. Richards' disposition is clearly defined. I mean, she has a hip fracture and she's going to require operative repair. Her care will be transferred to the general surgeon and her COVID status will be shared with the anesthesiologist as she moves to the OR. However, one of our greatest challenges in these patients that we're seeing with possible or confirmed COVID is identifying those that are really safe to go home and safe for discharge. The decision to monitor a patient in the inpatient or outpatient setting should be based on case-by-case basis using your best clinical judgment. The decision will depend on clinical presentation, requirement for supportive care, potential risk factors for severe disease, and the ability for the patient to self-isolate at home. Patients with risk factors should be monitored closely given the possibility of progression to severe illness, which we've seen, especially in the second week after symptoms arise. So it's helpful to view COVID-19 more as a continuum. So the NIH outlines severity of illness categories for adults. First category, asymptomatic, pre-symptomatic, second, mild illness. These first two categories are the patients that are likely safe for discharge. They can be managed at home with education on self-monitoring, isolation, and thorough return precautions. The third category, moderate illness. This is the more challenging category. These are the patients with evidence of lower respiratory disease, and the NIH recommends closely monitoring these patients with moderate disease. So this is the category that will be the greatest disposition challenge. And then the final two are severe illness and critical illness. These are the patients that are clearly ill. These will require admission, high likelihood of intervention, resuscitation. Our Emerging Infectious Disease Task Force is analyzing all the current data, all the current guidelines, and working to develop a COVID discharge algorithm for us. They're diligently working to complete this, and they will share their final recommendations as soon as they're available. I know there's probably many topics of interest that you'd love to hear about today, and unfortunately time does not allow, but I'm always available to answer your questions, to go through these and have a thorough discussion with you at any time. So feel free to reach out to me, and at this time I'll hand Ms. Richards over to Dr. Masrobian. Thank you very much.
I'm really going to focus most of my time on updating standards for preoperative testing and screening and availability and use of PPE. And I also want to touch very briefly with some references on airway management and a new topic we haven't talked about, patient blood management during a pandemic. If there's one slide you take home with you, it's this one today. This is the COVID surge study, which was a retrospective cohort study of over 1,100 patients at multiple centers throughout Europe. It examined the incidence of pulmonary morbidity and mortality in patients with diagnosed COVID having elective and emergent surgery. And what's truly informative about this is not what happened in patients over 70 or who had comorbidities, but in the younger cohort of patients. What you can see on this slide at the top is that particularly for males under the age of 70 in generally good health, there's still significant incidence of mortality with even elective major and even elective minor surgery if they were diagnosed with COVID. Now let's go really briefly into perioperative testing. You do have to have some sense of what the prevalence of COVID is in your region, and that's something you get from working with your hospital, by extension with your public health department, because some of the criteria on testing and the need for it will depend upon whether you have little or no prevalence versus a higher degree of prevalence. There's still a lag time from the infection date to the time you turn positive, and that's a false negative cause. Testing errors can also be a false negative cause. And I want to cite also this study out of Iceland that showed in patients who tested positive for SARS, 43% were asymptomatic, which is a sign that screening in and of itself may not be enough to detect people with COVID. So let's return to some of the key guidances in preoperative testing. Some of these are a little older and some have been updated. The original one came out from the American Hospital Association, operating room nurses, American College of Surgeons, and ASA back in April of 2020. The more recent ones are from ASA and the Anesthesia Patient Safety Foundation and CMS. And I think the statement below from CMS summarizes well their recommendations and of the others on testing. That testing should be prioritized for anyone undergoing a procedure or operation. The most common question we get from our clinicians is, my hospital only wants to do screening, is that sufficient? And the answer, unfortunately, is to some degree it depends. It depends on the testing capability and capacity of your facility. It depends to some degree, as I said before, on the community prevalence of COVID in your area. It is an ideal state to be able to test everybody having elective surgery, but not every facility does that. In that ASA APSF document just referenced, there are a number of examples of screening testing protocols for facilities. I'd encourage you to look at these three referenced up here from NYU, Partners Healthcare, and Evanston North Shore, because they illustrate very different ways spanning from testing everybody to testing based on a complicated algorithm. And I think these will provide some guidance to you with your own facility. Let's move on to PPE. All of these recommend as optimal practice anesthesia professionals utilizing PPE during aerosol generating procedures. We have not deviated from that stance at TeamHealth. As we got a little more comfortable with COVID, from April through May, 30 states allowed resumption of elective surgeries. Recent milestones have been illustrative. There's been a rise in COVID prevalence across many states in the U.S. We've had a resuspension of elective surgeries in 4 counties in Texas. Many Florida hospitals this week are at ICU capacity, more than 44, and some of our corporate clients, HCA and Tenet, are already starting to claw back a little bit of that elective surgery. So we're going to see these types of surges up and down for the coming months, if not longer than a year. So what my recommendation is that you will continue to see surges and that you should continue to utilize PPE regardless of what the results of the screening and testing are. I want to just end with 2 references for you. Airway management still is a critical part of what we do as anesthesiologists and anesthetists. The first document there is one we set up early in the pandemic about forming airway and line teams in your organization. This is something you may be asked to do again when you have a surge in your area, so I'd encourage you to relook at this document. The airway algorithm came out of New York Presbyterian Queens, where we have a practice. It's an excellent local policy on how to set up your airway team and what type of equipment you need and where you need it. And then lastly, I refer you, if you start to include proning of critical care patients in your armamentarium, that this document from the Society of Critical Care Medicine is an excellent resource for that purpose. And lastly, I want to raise one issue we haven't talked about before at length, and that's patient blood management. The American Association of Blood Banks has made a number of observations based on its members throughout this pandemic. Blood donations fall. More blood gets discarded during a pandemic. Activity of donors goes down. So the supply goes down, but the usage they're reporting is going up. So what we're recommending to our groups is that they, when possible, engage their hospital on discussions about blood supply, blood cost, blood utilization, and if needed, how do we integrate patient blood management into our perioperative management. And I point out this article, this hasn't even been published yet. This is scheduled to be published in Anesthesia and Analgesia. The lead author on it is our own Aryeh Shander, who is our Director of Education, and it is really a call to action for blood management in a pandemic, and he lays out in great detail the rationale behind it from the point of view of many countries. In conclusion, this will be with us for a while, and it's going to ebb and flow depending on your area and depending on how states open up. So be ready to be flexible, but always keep in mind that you should continue to use PPE, including a respirator when you need it for the right cases. Promote pre-op testing if the resource is there for all patients, and if not all patients, at least those who have procedures with a high risk of aerosolization. Continue to work with your facility on operational issues. Be prepared to jump back into what you did so well before, airway lines and proning teams. And if there's opportunity, initiate that discussion in your facility about patient blood management. This is how we'll bring value to our hospitals and to our patients during the pandemic. Thanks for your time today, and I look forward.
My goal today is to address the issues that we believe are most pertinent to the well-being of our hospitalists and our patients. Let me start by putting our current COVID trajectory in perspective. With this surge of daily admissions, many hospitalists are again facing intense anxiety and uncertainty. These feelings are competing against a desire and commitment to serve our patients. To all of you on the front lines of this pandemic, thank you. We are so appreciative of your courage, your expertise, and your commitment to patient care. We will be there to support you. The most important way we serve and support our hospitalists is through robust and proactive preparation. We have created resources and checklists that walk leaders through the major elements of COVID preparation. The checklists address issues such as creating a communication plan that ensures clear and transparent team communication, rallying the team and helping them connect with their purpose, reviewing plans and contingencies and optimizing collaboration with stakeholders, reminding the team how to connect with resources and support, and finally, having intentional and frequent connections with clinicians to share gratitude and recognition. Given our experience with rapid escalations in volume, a well-thought-out surge plan is essential. This includes an internal plan to add resources as volume spikes and a plan to reduce staffing and rest clinicians when volume slumps. The plan should include flexibility to modify coverage and staffing as needed and should identify when and how external resources, such as residents, non-hospitalist physicians, advanced practice clinicians, and telemedicine would be activated. Here's a link to those leadership checklists. Now that we've completed all of the proactive preparation, let's return now to our patient, Ms. Richards, and how we can deliver the best possible care to her in the setting of this pandemic. COVID has rapidly forced us to change the approaches we usually employ to connect with patients and families. Things like physical distance and PPE impose new types of hindrances to nonverbal and verbal communication. As we communicate with Ms. Richards, we have to utilize discrete strategies to achieve clear and compassionate communication. We express empathy through verbal statements, such as acknowledging and validating her emotions. We enunciate, increase our volume, and speak slowly. Finally, one member of the team will update the family on at least a daily basis. Now, in typical hospitalist fashion, I will now hand off the care of Ms. Richards to Dr. Sahu.
Thanks, Rohit. So we know that Ms. Richards has an O2 sat of 92% on room air and is requiring supplemental O2. Given all of the evolving treatment plans for COVID patients, a COVID treatment algorithm was developed and is available on Zenith. By answering a few questions about this patient's clinical status, we can determine based on current evidence what treatments are indicated for this patient based on these 5 general categories of treatment modalities available for COVID patients. Based on the questions that I've answered for this patient, based on the clinical information we know that she is eligible for antiviral treatment, including remdesivir IV 200 milligrams loading dose on day 1, and then 100 milligrams Q daily times 4 days for a total of 5-day course. Of course, we should monitor renal and hepatic function. This dose may change based on her clinical status, but how she's doing right now warrants a 5-day course. She also warrants dexamethasone, PO, or IV 6 milligrams Q daily times 10 days or until she's discharged. We should, of course, monitor for hyperglycemia, adrenal suppression, or infection, especially bacterial or fungal. She may be eligible for convalescent plasma as well, which is currently only indicated in the context of clinical trials in the United States. We again should monitor for transfusion-associated circulatory overload, transfusion-related acute lung injury, or severe allergic response, given that this is convalescent plasma. In order to see if she's eligible for anticoagulation, I can also consult numerous resources that we have available on the Zenith channel, including this COVID coagulopathy video with links as shown. There's a lot of other clinical information that can be found in the Zenith channel as well. Advanced care planning should also be addressed in this patient early on in addition to prescribing treatments. We should always avoid life-sustaining treatments when unwanted by patients, not just in COVID-19, but especially in scarce times. Resources should really be saved for the patients who truly want the resources. And providing high-intensity care may put other individuals at higher risk for COVID, especially when we're talking about the risks associated with intubation. The talk should also include understanding patients' values and goals, especially related to code status and CPR. The following protocol can be used to conduct that end-of-life discussion in COVID-19 patients especially, keeping in mind a lot of this may happen over the phone. You can set up a meeting in the facility or over the phone, introduce yourself, your role and purpose, establish what the patient and family already understand, provide clarification, establish what the patient's hopes are for the future, and inform them that you're there to help for that, and approach advanced care planning as a progressive, never a solitary discussion. I'm really glad that we had this conversation because despite all the treatments she was given, unfortunately Ms. Richards decompensated and had a code blue called overnight. I'm going to hand it over to Dr. Sundaraj to take it from there.
Thank you, Dr. Sahu. The priority for any COVID code blue is to safeguard the essential staff while providing care for our patients. We need to identify roles for everyone who will attend, both inside and outside of the room. Inside, we need an airway manager, intubator and RT, an RN for meds, a compressor RN to assist, and outside we need a code leader, an RN recorder, a PPE monitor, and or a pharmacist. We need to assure that the announcement specifies that the patient is COVID positive to identify the need for appropriate PPE by using terminology such as protected code blue. All code responders should use appropriate PPE, cover the patient to minimize risk of aerosolization. For example, cover the entire patient, including the face, with a clear plastic sheet. Continue non-invasive ventilation and intubation under the sheet. One person should administer chest compressions with one person donned with PPE at the doorway to relieve and rotate. The crash cart should remain outside of the closed room to avoid contamination. Initial rounds of medications and supplies should be maintained in a plastic bag within the crash cart and brought in by the RN initially. The follow-up meds and supplies may enter the room in a transfer bin at the door. Consider the cause of the arrest in order to prioritize intubation or defibrillation to save exposure time. Now, Ms. Richards survives the code and has maximized most therapies available to her and will go on to ECMO. ECMO is a heart-lung bypass system that circulates blood through an external artificial lung, oxygenates it, and delivers it back into the bloodstream. ECMO is indicated in COVID patients who have high risk of mortality without severe comorbidities, prolonged time on vent, or older age. This decision tree to initiate ECMO is on the slide, which uses PO2, FiO2, pH, and PCO2. Also consider the significant resource need for use of ECMO prior to initiation. Now Ms. Richards has pulled through with the great care she received. What makes discharging a COVID patient unique? We need to verify that the discharge location is a private location, verify the contact information for both the patient and caregiver, verify there's adequate support and resources available at home to avoid the need to leave home for the next 2 weeks. We need to confirm patient is available to manage ADLs and instrumental ADLs independently or with support of a caregiver at home. If not, consider an alternate discharge plan. Confirm the support for the patient to have at least 1 to 2 weeks of food and supplies while in quarantine. We should also ensure that the patient has at least 14 days of medication supply and also ensure that the patient's supply needs in addition to DME are also met, such as surgical masks and cleaning supplies. Lastly, we should also verify that the patient has a ride by a private vehicle with the patient wearing a mask during the transport. If not available, please set up a Medicar or alternate transportation. There are also specific home instructions that we have to provide to the COVID patient and the caregiver at home contacts addressing things like self-isolation, PPE, hand hygiene, monitoring for symptoms, etc. Now, Ms. Richards will not be going home, but will require a skilled nursing facility. There are current challenges with skilled nursing facility transfers, including strict criteria or refusal to accept COVID patients. If significant barriers exist in accepting COVID patients to SNFs, consider creating a SNF task force with key stakeholders to collaborate together and create a transfer algorithm for SNF transfers for COVID patients. Use the sample COVID SNF transfer form from Texas on the slide as a starting point to creating your own that would satisfy all the stakeholders. Now, Ms. Richards has been cleared for discharge and accepted to the local skilled nursing facility.
All right, now Ms. Richards is ready for rehab. She's finished her hospital course and now is ready for her rehab therapy to get stronger. So first we began any new admission to the facility trying to get a good handoff from our acute teams. So in this case, we would reach out to our hospital medicine TeamHealth team and just go over any issues that they may have had or she may have experienced while in the hospital, anything specific they would like us to check up on, because we don't want to make sure we miss those kind of things. She will be under the care, of course, of a physician and APC dyad who works closely with everyone in the building, everywhere from nursing to dietary, to create a personal plan for her. And if with anyone this day and age coming into a facility, the very first thing we got to ask is, has she been screened for COVID? Let's just start for a second and talk about any patient coming into the rehab. These patients come from home sometimes, they come from other facilities. So let's start with an example where they have not been screened. So these patients are usually admitted to an area that's a little bit more isolated than other patients. So they can be watched a little bit closer. Sometimes it's with COVID positive patients or those that are at high risk. And then per the guidelines of the facility and the corporate structure that oversees the facility, and of course CDC guidelines, they're screened until they're negative. We'll talk about what happens then in a few seconds. So let's just say she has been screened and she's negative. So these patients are still usually watched a little bit more closer, maybe in a semi-isolated area for a couple of days, just until they don't recheck, so we can recheck them and make sure they are negative, just before they move on to more areas that could be socially interactive, dining halls, the full rehab gym, that sort of thing. So let's go now to a patient that's been screened and they're positive. So these patients are admitted more to an isolated area. If the facility is large enough, let's say they may have an A, B, and C unit, for instance. They may dedicate Unit C for all COVID positive or high-risk patients. If that happens while they're there, of course, they're treated appropriately and rechecked frequently until their symptoms clear. Now, once they are negative, or earlier, like we said, patients are negative, then they can, and symptoms are resolving or there are no symptoms, then at that time they can be moved to areas where they may be quote unquote less isolated and maybe like what's the full gym unit, for instance, or the swimming pools, that kind of thing. Now, go back to Ms. Richards, along with any other patient too. While they can't expect just as in the hospital, all your providers will be wearing appropriate PPE, hats, gowns, gloves, and they'll look just like they were when she was in the hospital. Now, another personalized care plan, especially around COVID now, it's even more important. We try to personalize their care, especially around medications. So they may be on a medicine. Ms. Richards has hypertension. She may be on medications 2 or 3 times a day. We try to limit that to once a day, just to reduce the frequency and contact to try to contain exposure of the virus. Diabetes, same thing, more long-acting insulin. Frequency of glucose testing may go from 4 down to 2 times a day. All this, again, in order to reduce the frequency of spread of COVID. Nebulizer treatment is something very specialized. These obviously can transmit particles in your lungs. So if we cannot move them from a nebulizer to maybe an endosed inhaler, These have to be in the patients need to be in a private room, or the treatment has to be delivered in a private room, and then they're isolated for several minutes, sometimes hours, until after that treatment. For the return to the roommate's allowed to come in, that sort of thing. Telehealth's another area where it has changed with COVID. IT software used to be stable. Patients were moved into that treatment area. Their interviews were conducted, then they moved back to the rooms. Now the equipment comes to the patient's room, actually. So, of course, this is going to require more frequent cleaning for the staff, those sort of things. With any of this said, COVID or not, when these kind of events happen, this is very traumatic to these folks. They were at home doing their thing, and now all of a sudden something has changed their life, sometimes forever. So now with COVID also, much more isolation than normal. So this can play on your mental health also.
I'd like to speak to you today regarding COVID-19 and pregnancy. There are a number of immunologic and physiologic changes that occur during pregnancy that do make women more susceptible to viral respiratory infections. While pregnant women are now known to be at increased risk for certain manifestations of severe illness as a result of COVID-19, resulting in ICU stays or the need for mechanical ventilation. Pregnant patients do not appear to be at increased risk of death associated with COVID-19 compared to non-pregnant patients. And they do have a similar clinical presentation as non-pregnant patients as well. While the data is limited regarding COVID-19 and pregnancy, it is somewhat reassuring. We do know that there is no definitive evidence of fetal transmission. Thus far, there's only been one reported case of a fetal death related to a mother with multi-organ system failure. There is an increased risk of adverse pregnancy outcomes such as preterm birth, but it is thought to be iatrogenic and not a result of COVID-19 itself. Most of the medications that we use to treat preterm labor or preeclampsia can be used in patients with COVID-19, but we need to do so with caution. Full-term patients that are either asymptomatic or mildly symptomatic, however, less than 39 weeks gestation, can still be managed expectantly and does not require them to be delivered as a result of their COVID-19. Antenatal testing should be reserved for the normal obstetrical indications and do not have to be increased as a result of COVID-19 infection. Some of the proposed therapies such as azithromycin, remdesivir, dexamethasone, or even convalescent plasma have not been tested in pregnant patients. However, we do know at this time that none of those therapies are contraindicated in pregnancy, and so those patients should be treated as any other patients if indicated. Pregnant patients that are critically ill that require mechanical ventilation should be considered for prophylactic heparin or low molecular weight heparin if there are no other contraindications. Whether or not to fully anticoagulate those patients should be individualized and according to the hospital protocols and practices at your institution. The timing of delivery for those positive patients is critical and is a very difficult and complex question that we try to address. We do know that patients that are at 39 weeks gestation, if asymptomatic or mildly symptomatic, should be considered for delivery in order to decrease the risk of worsening maternal status. The mode of delivery, however, should be based on routine obstetrical indications. Another important point to note is that the second stage of labor is considered an aerosolizing procedure, and so patients should be encouraged to wear masks, and healthcare personnel should have appropriate PPE in place. For our postpartum patients that are COVID-19 positive, they can be susceptible to fluid overload, so care does need to be taken to monitor strict eyes and O's, especially in the initial 24 to 48 hours postpartum. NSAIDs can be used for pain management, especially for those patients that are asymptomatic or with mild or moderate symptoms, to avoid the use of narcotics. The duration of their inpatient stay should be based on the severity of their symptoms and not necessarily any other clinical factors. For our postpartum mothers that are COVID-19 positive that want to breastfeed, they should be encouraged to do so. While the data is limited, there is no indication that there is any transmission of the virus through breast milk, and there is a potential benefit to the baby from that antibody protection. If isolation is not feasible between mom and baby, the mother should be counseled to wear a face mask or face covering and practice appropriate hand hygiene techniques prior to each feeding and anytime they're in close contact with their baby. In summary, there is a limited amount of data regarding COVID-19 in pregnancy. However, we do know that maternal death is rare. There are some studies to suggest that up to 2/3 of pregnant patients that test positive on admission were actually asymptomatic. As a result, ACOG does support the universal testing of all pregnant patients once admitted to the hospital. And whenever we're caring for a pregnant patient that does have COVID-19, it is important to make note that it should be a multidisciplinary approach, including the primary obstetrician and any other specialists involved in the care. Thank you so much for allowing me to present today.